All right, so welcome again to our weekly virtual live lectures. I'm going to teach for probably around 30 minutes, and then we will have a case discussion at the end where I will ask you a few questions and give you a chance to engage with the case, and hopefully it will help us to consolidate, the theory that I would be covering. So, like I said, we have already done the voting. Most of us are happy, some are okay, but by God's grace, we don't have anyone who is sad today. So we are happy about that. So in terms of the agenda, I will just introduce you briefly to our school as usual, because we always have one or two new people. Then we will quickly go to the program in terms of our topic for today, patient monitoring and drug switches. And hopefully at the end, we have enough time for discussions. So I represent Aqua Training School. We have a vision where we want to see, everyone, especially our health workers, achieving their full potential. Hence, we select, training programs, which we know that can actually help people to transition to new roles or even transition from working in a hospital to a primary healthcare level, but importantly for nurses to be able to operate independently. These are some of the programs, but I wanted you to pay attention to the third program, which is the new HIV management guidelines. We now have this training program online, and it is free to you. We have managed to secure, a sponsor who's willing to train everyone at no cost. All you need to do is to register and do the program. We started it last week. We already have 140 or so nurses and clinical associates and other healthcare workers who are part of the program. So I hope some of you would have an interest, to upskill and improve your knowledge. So do register for that training program. I will share this slide again towards the end of the program. For registration, just visit our website, register and start. You can also email us if you struggle, or even call us during working hours for that specific program. Right, so our topic today is patient monitoring and drug switches. I want to achieve three things. One is to ensure that you have a better understanding of treatment failure, but also to improve your knowledge and skills around safe single drug substitutions and switches for regimens. And then we will then at the end discuss a case which then would make it our topic easy. So the case which we will discuss at the end is about Lerato, who is 18 years old. She's a female who presents with a history of being on antiretroviral drugs for 1 year and 1 month. She is currently taking tenofovir with lamivudine and efavirenz. So this is her ART drug regimen, and she's also taking cotrimoxazole prophylaxis therapy. She has no complaints today, but reluctantly reports that she's been missing, doses over the past months. She is not pregnant, and she's on an IUCD. So she's on a long-term family planning, option, IUCD, which is generally preferred. Her vitals are okay, examination, no findings. When she was 6 months on treatment, her CD4 count was 350, and she had a viral load that was suppressed because it's less than 50, less than 40. Now it's 1 year, 1 month. So she's coming in to check her results, which were done last month, and her CD4 count has since dropped from 350 to 110. And the viral load, which was suppressed at 6 months, it's now 20,000 copies. So there are three questions. What do you suspect is occurring? So we will discuss this towards the end after the teachings. And then, is there an indication of stopping or switching regimens? Why or why not? And then also, what is your plan for Lerato at this point in time? So think about these questions as we go through today's lectures, right? So in terms of monitoring patients, is that if you look at the current recommended first-line regimen, which is what we call TLD, which has tenofovir, lamivudine, and dolutegravir, right? There isn't a lot of monitoring that needs to be done, except for a creatinine, because the patients are taking tenofovir, right? Lamivudine, generally, there's no blood test that we need to do. Dolutegravir, no blood test that we need to do. It's the same as TEE, which would be tenofovir, emtricitabine, and efavirenz. Tenofovir, yes, we need to do a creatinine or creatinine clearance, right? Emtricitabine is the same drug as lamivudine. Both drugs do not need any test to be done. And then efavirenz also does not require any test, right? So in terms of the timeline for doing tests when patients are on ARVs, there are tests that we need to do at baseline. That is when or before you start ARVs. When patients are 3 months on ARVs, at 6 months, 1 year, and then from there we do certain tests every year, depending on the regimen. So if a patient is taking tenofovir, the T in both regimens, right? We would have to do a creatinine at baseline, then 3 months, 6 months, 1 year, and then every year from then onwards. Then a CD4 count, we do it at baseline, and then at 12 months, we don't do it anymore unless indicated clinically. And here we mean that you will do a CD4 count if a patient is taking prophylaxis like cotrimoxazole or fluconazole prophylaxis therapy, and you want to consider stopping that therapy, you might need to do a CD4 count, or when they are sick and you want to check if their CD4 count is dropping or not. But for the majority of patients in their lifetime on ARVs, they will get only 2 CD4 counts, the baseline one and the 12 months one. A viral load, we don't do it at baseline. The first viral load is done at 6 months, then 12 months on ARVs, and then annually, right? Patients who might be taking a lopinavir, ritonavir combination, we can then do a cholesterol test at 3 months only. We no longer do baseline cholesterol tests in patients. And if this 3 months cholesterol test comes back as normal, we do not need to repeat it again. That's the point. So I'm continuing from there. And then I think at the bottom here, there's an important, point to consider, that an HB to check for anemia and also hepatitis B surface antigen, these 2 tests, we need to always do them anytime we want to switch a patient from first line to second line ART regimens. And I will tell you later why that is important, right? So just note, pay attention to the fact that no baseline cholesterol needs to be done. Just know that there's other assessments. As always, I always include this slide, in all presentations generally, to say there's always other things that you need to do, for example, education about side effects, TB screening adherence, education about safer sex. If it's a female, we want to know her pregnancy status, weight and BMI, WHO staging, hepatitis B, pap smear. So just remember to always approach, your patients comprehensively, and not only deal, with ARV related assessments. HB only done when patients are going to take zidovudine, and then ALT only done if patients are going to be taking nevirapine. So the viral load is now the preferred patient monitoring approach. So if you follow the history of the HIV program, when we had no blood tests at all, we relied on how patients present clinically. So we then used the World Health Organization clinical staging system to say, oh, this patient is now stage 4, they need ARVs, or they are even failing treatment, right? But you would know that before someone gets a stage 4 clinical condition, they would have a CD4 count that is dropping. And before a CD4 count starts to drop, generally the viral load would have been high, right? So we then introduced a CD4 count, which then we relied on over time to say when a CD4 count drops below 200, it means patients have what we call immunological treatment failure, right? But by the time someone's CD4 count drops, it means they would have been failing for a while because their viral load would have been high for a while. Hence, a viral load becomes more sensitive and more reliable than a CD4 count in terms of monitoring and tracking treatment success. So that's very important for us to know. So we no longer use clinical treatment failure to diagnose treatment failure. We no longer use immunological, where we rely on the CD4 count, but we use a viral load. We still do the CD4 count to assess who needs to start what kind of prophylaxis in terms of those treatments. So the viral load now becomes the preferred and the most important test to be done to monitor treatment success for patients who are HIV positive on ARVs, right? So, and then what is then, when you start someone on treatment, ARVs, what is your expectation, right? Because if you know the expectation, it means if the expectation doesn't happen, then it means probably there are problems and maybe the patient is now not winning, as we would have liked to see. So virological suppression, which is the ultimate goal of putting patients on ARVs, is defined as a viral load of less than 50. So when you start a patient on ARVs and they take ARVs for more than 3 months, right, we expect the viral load to be suppressed, right? With dolutegravir, suppression even happens earlier, like around 6 weeks or so from the time when they started, their ARVs to the time to suppression. In other words, when you start someone on any of the South African regimens, and they are HIV positive, and you do the first viral load at 6 months, you have an expectation that the viral load must be suppressed, right? If at any given time you have a patient who has taken ARVs for more than 3 months and they have a viral load more than 50, you should be concerned, and it is a medical emergency and it requires urgent attention. Because when patients have a high viral load, it means their virus is very active, in the blood, and it starts to replicate, making, baby viruses in the presence of the ARV drugs. What that happens then, it means it gives the virus a chance to mutate, to change, to get used to the ARV drugs, where now a patient ends up having treatment failure, or where we say a patient has failed. So in essence, any patient who has taken ARVs for more than 3 months and they still have a detectable virus in the blood, it's an urgent medical ART emergency, and those patients would need a thorough assessment and to ensure that there's quick action before they develop resistance. So I've already explained this to say, as part of the HIV life cycle, where HIV infects our cells and it makes more viruses, if it manages to replicate in the presence of the drugs, we get mutations where certain proteins on the virus change, and when those things change, they make our ARVs to not work anymore, and then we end up with a patient who has failed treatment. Now, ARVs are not the same. We've got certain drugs that have a low barrier to resistance. And when we say a drug has a low barrier to resistance, we mean drugs like nevirapine and efavirenz. These drugs would require one change. So one change, if the virus changes once, it develops one mutation, right? Just one mutation would render these two drugs ineffective and they can no longer work anymore, right? And these patients would then need a second line ART regimen sooner, versus if they were put on a different drug regimen, which had maybe dolutegravir, because dolutegravir is introduced in our guidelines today because, amongst other things, besides that, it's got a very low side effect profile, it suppresses the viral load very quickly, but it has a high genetic barrier to resistance. That means when patients are taking a dolutegravir-based regimen, even if they are forgetting time and again, it is very difficult for the virus to develop resistance to dolutegravir. And this is because drugs like dolutegravir and lopinavir-ritonavir require multiple mutations, not just one mutation, but multiple mutations to render, the drugs ineffective. So we prefer regimens where we give our patients a very good regimen, simple to take once a day, but we also know that if they take that drug on a daily basis, they can take it for the next 20, 30 years without the need to switch or to change. So remember, we said that anyone who has a high viral load, more than 50 copies, it's an HIV medicine emergency. We need to thoroughly assess them and take appropriate action. Your assessment would include what we call A, B, C, D, E, right? A means we have to do to enhance adherence and assess, are you taking your medicine? What challenges do you have? Have you ever missed doses? And then how do you remember to take your medicines? What other drugs are you taking? Are you coping? And then also socially, is there a history of substance abuse, poor social support? And do they have to hide their medicines all the time at home because they have not disclosed to their partner, and so on? Then sometimes it's because they have other infections that they have, which might then contribute to them taking more tablets or becoming sick and failing to take their ARV. Sometimes the drugs they take, like for TB drugs, would interact with the ARVs, making ARVs less effective. So especially with children, pay attention to the dosages. You'll find that sometimes the kids have been prescribed the same 5 meals, for the past 2, 3, 5 years, and as they grow up, that dose becomes an underdose. So you have to check adherence, infections, the dose, drug interactions, and then sometimes, depending on the regimen that they're taking, if they're taking dolutegravir and lopinavir-ritonavir, we might actually need to assess them for resistance and do some resistance testing. So a very important, very simple approach to assessing patients who need further assessment. So we also need to look into first line virological treatment failure. So what is the definition? How do you know if someone has actually failed ARVs? So the first part is that for males and females who are non-pregnant, right? We define virological treatment failure as a patient who has a viral load more than 1,000 on 2 consecutive occasions. So you need 2 viral loads that are more than 1,000 taken 3 months apart. And during that 3 months, there must have been some support, enhanced adherence support, where you ask the patient, you want to see them every month, you want to bring a treatment supporter from home, you are doing problem solving. And you can only say someone has failed treatment if they have taken ARVs for a minimum of 6 months, right? We're talking about non-pregnant cases, right? And then if you look at in pregnancy, it's almost the same, except that now we are very strict. We are saying a viral load above 1,000 on 2 occasions, 1 month apart. We can't wait for 3 months. In pregnancy, we don't have time, because if we wait for 3 months, they will deliver. Women would deliver with high viral loads and we end up with a child who has a preventable, incurable disease, which we could have done something about. In pregnancy, we count 3 months on ARV. So we expect pregnant women who have taken ARVs for 3 months or more to have a suppressed viral load. In children, it's 2 consecutive viral loads 3 months apart after 6 months of ART. So it's the same now as in adult males and females. So if you do a viral load and you have your results, so you have done a viral load, you have the results in front of you, how then do you act on those results, right? So a viral load of less than, if the results come back and say, well, the viral load is less than 50, then we are happy. We celebrate with the patient, we congratulate them and say, well, you have done well, but we still need to provide some level of adherence counseling to ensure that they continue to adhere. If the viral load is between 50 and 1,000, so you get a patient who has a viral load, let's say it comes back, it's 600 or 800. It's very difficult to determine whether that is by chance or there is a problem. So generally, we would do adherence very carefully, see the patient every month, and then repeat the viral load after 3 months. And then based on those results, we then manage them as needed. If a patient now, let's say you do your 6 months viral load, it comes back as more than 1,000, it's 5,000 copies, and they are on an NNRTI regimen. That means they are taking either efavirenz or nevirapine. So it will be tenofovir, emtricitabine, or lamivudine with efavirenz or nevirapine, not DTG-based regimen, right? You would do adherence assessment and support. You would then repeat the viral load in 3 months. We need to check the hepatitis B and HB status, because we know when they fail that regimen, there's a possibility that we would need to give them zidovudine. And before you give AZT to patients, you need to check their HB for anemia, right? We check hepatitis B status because whenever a patient has HIV and hepatitis B at the same time, we should never stop tenofovir. So those patients, even if we switch them to the second line regimen, tenofovir needs to be kept in the regimen so that we also manage the hepatitis B virus correctly, right? Now, remember, you have repeated the viral load after 3 months. Now, the 3 months result can either come back as suppressed or not suppressed. If the first viral load was more than 1,000 and the second viral load is less than 1,000, we are happier. We still do adherence, and we want to repeat the viral load in 6 months' time. So we don't need to switch. We don't need to stop the current regimen. However, if the first viral load was more than 1,000, you did adherence, you repeated it in 3 months' time, and the 3 months viral load is also more than 1,000. Now you have 2 viral loads, right? More than 1,000 taken 3 months apart, right? So now we believe now, okay, this patient now has failed treatment. You should not delay patients who have high viral loads. Actually, if you look at studies, even before you do your second viral load, just on a first viral load more than 1,000, more than 90% of patients with a single viral load more than 1,000 have already developed mutations. The virus has changed. There's nothing else you can do to unchange the virus, right? They need a second line regimen, right? And then it's important to check hepatitis B and the HB tests before you give them the new regimen, right? If you have a patient who has a viral load more than 1,000, but they're taking a dolutegravir-based regimen. Remember what we said about dolutegravir? It has a high barrier to resistance, the same as lopinavir to ritonavir. So we don't believe that people who take dolutegravir or lopinavir, ritonavir, who have high viral loads are failing treatment. The majority have either stopped taking treatment, right? Or they're taking other traditional and modern medicine drugs that interact with dolutegravir and are reducing its effectiveness. So that's why now the definition of treatment failure for patients who are taking dolutegravir or lopinavir, ritonavir regimens, right? We need to have at least 3 viral loads that are more than 1,000. So not just 1, not just 2 like here, but 3 viral loads. And they must have taken dolutegravir or lopinavir, ritonavir for more than 2 years. So we don't believe that anyone can start dolutegravir today and next year they fail dolutegravir. So they must have completed taken dolutegravir for 2 years, right? and we have 3 consecutive, viral loads that are more than 1,000, then we start to suspect that they are probably failing treatment. That's very important. And then also assess their clinical and immunological failure. So even if you have 2 viral loads, but if a patient now develops a stage 4 medical condition whilst taking dolutegravir, it means now we have evidence that they have actually failed treatment. And even in this instance, it's very important that we assess the hepatitis B and also the HB status of these patients to ensure that when we now have to stop a regimen that has TDF to a one that has zidovudine, we do it as safe as possible, right? Now, how then do you manage a high viral load, right? So it's just a summary of what I have already discussed. So what would happen is that you would have a patient who is due for a viral load, whether it's a 6 months or 12 months viral load. You do your viral load as scheduled. That is the most important thing. We have to monitor patients who are on ARVs and ensure that viral loads are done. So you do your 6 months viral load or 12 months viral load, it comes back suppressed. We are very happy. You are like, yay, things are going well, right? Or you do it, it comes back as more than 1,000. We become worried now that, the viral load is going up, what's going on? So we therefore do a thorough assessment. You do your adherence, you check for any infections they might have. Are they taking the drugs? Are they taking the right dose? Any other drugs and food that they are taking which might interact and reduce the effectiveness of the drugs? Do we need to assess for resistance? Once you have done this, and this is not a once-off kind of activity, every month when you see patients with high viral load, and A, B, C, D, E has to be done, right? And then once you have identified the gaps, you need to implement those, seeing the patient every month, bringing a treatment supporter and adjusting drugs as needed. Then repeat the viral load in 3 months. All right. And this would apply for all those who have some virus in the blood, right? So even if the viral load is not more than 1,000, but it's 600 or 800, the fact is it is not suppressed, and we need to do A, B, C, D, E, and intervene, then repeat the viral load in 3 months' time. So now you can see now we are repeating the 3 months. Remember, we had the first viral load, which was high. We want to repeat, after 3 months. Now, at 3 months, you do the viral load, right? If that viral load comes back suppressed, we are very thankful. It was very high. We intervened. It is now suppressed. We celebrate with the patient, right? If it's still, if the second viral load that is taken at 3 months, it's still between 50 and 1,000, we need to continue adherence and then repeat it in 6 months. And based on the 6 months viral load, if it is suppressed, then we go this route. If it is now more than 1,000, then we know. Because remember, in this week, you had the first viral load, which was more than 1,000. You intervened for 3 months. You repeated it at 3 months, and it is still high. Now you have 2 consecutive viral loads more than 1,000. If your patient is taking an NNRTI regimen, efavirenz or nevirapine-based regimen, they have failed. We classify them as, my patient has failed, and I need to stop this regimen and give my patient a new regimen, right? Remember, when a patient has a high viral load on efavirenz or nevirapine, we said these 2 drugs have a low barrier to resistance. They have failed. There's nothing you can do. I know we like also telling them, or no, put on a condom, someone is infecting you. Yeah, but it won't reverse the mutations, right? Putting on a condom is too late for that. We still encourage condom use, but not as an intervention for treatment failure. They need a new regimen. If someone has 2 viral loads and they are taking a dolutegravir or a protease inhibitor, that means lopinavir, ritonavir-based regimen, we cannot conclude that they have treatment failure just on 2 viral loads. What do we need? They must have taken dolutegravir or lopinavir/ritonavir for at least 2 years. And we need at least 3 viral loads that are high, unless if a patient presents with clinical signs that they are failing treatment, like they have a declining CD4 count, or they are developing stage 3 TB or cryptococcus meningitis. We won't wait for 2 years. We would therefore need to assess them and then quickly stop that regimen and give them a better regimen. So that's how you classify and you manage your patients. And in terms of choosing now your second line ART regimen, right? If a patient is failing an efavirenz based regimen, your second line regimen must be dolutegravir. Don't move from efavirenz straight to lopinavir/ritonavir without a reason, right? Unless if there is a reason why you cannot give dolutegravir. For example, it's a pregnant woman who is in her first trimester, especially the first 6 to 8 weeks. You are like, no, I want to avoid the use of DTG. Therefore, yes, you can move from efavirenz to lopinavir/ritonavir, right? But generally, for most patients who are failing an efavirenz-based regimen, we would confirm them with 2 viral loads, 2 consecutive viral loads taken 3 months apart, and we confirm they are failing. We then give them dolutegravir-based regimen. If someone has a high viral load taking dolutegravir, we don't just switch. We wait. Remember, they have to have 3 viral loads, and they must have taken dolutegravir for 2 years, right? Unless if they become very sick clinically. Then if we confirm failure, we would then need to switch them to a lopinavir-based regimen. So that's how it works. Also, if a patient is taking a lopinavir-based regimen and they have a high viral load and they were never on DTG before, you can actually stop this regimen and give them a DTG-based regimen. But they need to meet the criteria for treatment failure: 2 consecutive viral loads 3 months apart, or 3 consecutive viral loads taken over 2 years, or if a patient presents with a significant clinical condition which needs attention. So in terms of switching, if you look at the NNRTS, so someone is coming in, they're taking tenofovir with lamivudine and efavirenz, which is quite common, right? We don't need to do any resistance testing. All you need is 2 viral loads. 2 viral loads that are more than 1,000 taken 3 months apart, right? And then you need to do an HB and hepatitis B status. So if the hepatitis B status is negative and someone has 2 viral loads taken 3 months apart that are more than 1,000, your preferred regimen is then zidovudine, lamivudine, and dolutegravir, right? They have failed an efavirenz-based regimen. You then switch them to zidovudine, lamivudine, and dolutegravir. If you have to give them dolutegravir, but it's a pregnant mom, she's in the first trimester, or there's other drugs they're taking which would affect dolutegravir, you would rather not give dolutegravir and give what? Lopinavir/ritonavir, right? Or in another scenario, the patient is taking tenofovir, lamivudine, and efavirenz. They have 2 viral loads, more than 1,000, taken 3 months apart. So you have confirmed that they are failing. You want to check their hepatitis B status. It comes back positive. That means you are not allowed to stop tenofovir in that regimen, right? So you'd give them zidovudine, lamivudine, dolutegravir, but you keep your TDF in the regimen. So the patient will take 4 drugs: tenofovir, lamivudine, zidovudine, and dolutegravir. The tenofovir is kept in the regimen to manage hepatitis B. However, zidovudine, lamivudine, and dolutegravir would then control HIV because we are treating 2 viruses. That's very key. Like I said, any patient who's failing, who's got high viral loads on dolutegravir or lopinavir/ritonavir, they require a resistance test. And from a nursing perspective, whether you are NEMAR trained, you are not going to be able to manage these patients. As soon as a patient has a high viral load on dolutegravir, they need to be assessed by a doctor, a clinician at one of the HIV clinics in your region, so that the appropriate regimen can then be provided as needed, right? NIMART, you're not allowed to necessarily manage patients who are failing, because these are very complex patients and we have to do a resistance test and the interpretation is quite complex. However, we do provide advanced clinical care training for nurses, and if you attend, you will then be able to manage these kinds of patients, right? So again, let's look at children. Remember, children have different regimens, né? Compared to adults. So if you have a child who's failing treatment and they're failing efavirenz, right, you have to check their weight. Remember, children can only take dolutegravir 50 milligrams daily if their weight is above 20 kgs. That's why this algorithm is the way it is. So you have a child who's 3 years old with a weight of 15 kgs. If they fail efavirenz, right, their weight is less than 20 kgs. Therefore, the next regimen will be 3 drugs, including lopinavir, ritonavir. However, if it's a 7-year-old child with a weight of 31 kgs and they have 2 viral loads more than 1,000 3 months apart, you can stop efavirenz-based regimen and give them a dolutegravir-based regimen. Just remember, any patient who develops a high viral load on a dolutegravir or on a lopinavir, ritonavir-based regimen, we need to refer them for resistance testing, but importantly, to be assessed by an expert as needed, right? So that's very key. Again, just to summarize, children, if it's a child, remember children, their standard drugs would generally include abacavir with lamivudine and efavirenz. Some of them are on zidovudine, lamivudine, and efavirenz. Some of them are on TDF, lamivudine, and efavirenz. If they have 2 viral loads more than 1,000 3 months apart, they have failed. Now you need to decide which regimen are you going to give. It depends on the weight. Children less than 20 kg, you can't give dolutegravir. Therefore, you'll give the next regimen, which would have lopinavir, ritonavir. If the child's weight is above 20 kgs, you can choose the best 2 NRTIs, lamivudine and zidovudine, plus dolutegravir, because now their weight allows us to give dolutegravir. On this side, from a NIMAR perspective, you are not going to operate. From a nursing, is out of scope. As soon as you have a patient who's got high viral loads on dolutegravir or lopinavir, ritonavir, they need resistance testing and you need to refer them to a specialist center, right? So remember, as you switch to second line, you have to check the HB or FBC of your patient, so that you can assess them for anemia. And then hepatitis B surface antigen is done so that we know whether we need to stop TDF or continue. If you're going to give them lopinavir, ritonavir, you would then do your cholesterol levels at 3 months on ART, right? So in summary, dolutegravir is a game changer. It's part of our weapons of mass destruction against HIV. It has a high barrier to resistance. It's well tolerated. There are some drug-drug interactions which we must pay attention to, and also it's been implicated in neural tube defects in children. There's a signal. It's not really a confirmed thing. We haven't seen cases, in South Africa, but maybe in the next few years we might. A viral load is said to be suppressed when it is less than 50 copies per mil. Any patient who has a high viral load requires urgent action, and we have to thoroughly assess them using the ABCDE assessment. We have to intervene and also repeat the viral load as needed. We should never switch one drug in a failing regimen. If a patient has a viral load of, 20,000, 30,000, don't play with drugs, because you'll make your patient to fail all the drugs, right? Someone who has a high viral load does not need one drug to be switched. you need to stop the current regimen and give them a new regimen, which would be a second line ART regimen. Those with viral loads between 50 and 1,000, we do not need to switch. They need to be monitored and be supported to ensure that the adherence, is done. Hopefully they resuppress, again. Otherwise, if the viral load goes above 8,000, we would then still need to act again. Virological failure requires a complete regimen switch. So when there's treatment failure, you don't play with drugs and stop one drug and give another drug, as you have seen. So that's very important. And then any patient who has a high viral load taking dolutegravir or API, lopinavir, ritonavir, for more than 2 years should then be referred to a specialist for assessment and hopefully for a resistance test to happen and for further management, right? So at this point in time, what I want to do, I want us to go back to this case. I want us to go back to this case and then see then how we go through it. So Lerato is an 18-year-old female. She presents with a history of ARVs for 1 year, 1 month. Currently, she's taking tenofovir, lamivudine, and efavirenz, and cotrimoxazole. She has no other problems, but she kind of like says, "Ooh, sometimes I forget, doctor. Ooh, on Saturdays when I go there and there, I forget." She's not pregnant and she's on a reliable family planning option. So everything else is okay, except that at 6 months, everything was going well. Her CD4 count was 350. Her viral load was less than 40 copies. Now at 1 year, which is now she's reviewing these results, her CD4 count has dropped significantly to almost below 100 cells, and her viral load is 20,000 copies. So there's a question: what do you suspect is happening here, right? So I want us to try to see. So what do you suspect is happening? I want to share a voting system so that we see. So there are your answers. Choose what do you suspect is happening. You have to choose one answer. Read through the case nicely and then decide, what do you think is happening? Yes, 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 yes. I'm happy to see what I'm seeing. Right. So a few more seconds and then I'm going to stop and then share the results and then we discuss this specific question. All right, so I'm gonna stop and then I want to share the results with you for this first question. So there are your results, right? So if you look at Lerato, in terms of immunological treatment failure, 3% of everyone here said that they believe that Lerato has immunological failure. So yes, she does have, because if you look at her CD4 count, right, it has dropped significantly to 100. It's difficult to confirm that because we would have wanted to know before she started ARVs, what was her CD4 count? If this current CD4 count is below her pre-treatment CD4 count, then we'll say she's got immunological failure. So there is some element of that. So your answer is not very wrong. Virological treatment failure, yes, we suspect. We have not confirmed, but we suspect that there is, because the question is, what are you suspecting? So yes, we do suspect to a certain extent that there is some treatment failure. Poor adherence, yes, she does say, oh, sometimes doctor, I miss doses, so we think maybe the issue is there. She doesn't seem to be taking any other medicines except the IUCD and cotrimoxazole. So we don't know of any drug-drug interaction. So good. Clinical treatment failure is difficult to confirm in this case because she has no symptoms. So she has no complaints. Her vitals examination is normal. Remember, we would say she's got clinical treatment failure if she develops a stage 3, stage 4 medical condition whilst taking ARVs, right? So I'm gonna stop sharing this. So there's a second question based on Lerato's history. It says, is there an indication of switching or stopping the regimen at this point in time? So she's got a viral load of 20,000. Her CD4 count is dropping. So what's your take? Is there an indication for switching the regimen? What's your plan? What's your plan? Giving you a few seconds. I know some of you can't vote for some reason. It's because of maybe your systems don't allow, but it's okay. I'm sure you have a position to say which one you think is relevant. Okay, 60% of you have voted. Come on, guys. Commit. Yay. Okay, so I'm going to end the voting. I'm going to end the voting. And then I want to show you your results so that we can discuss them. So around 78% said no, there's no indication, and 25% said yes. So yeah, so let's discuss it. So the question is there an indication for switching at this point in time? We only have one viral load. Yes, this viral load is scary. It is very high. It's 20,000 cells. I mean, it's 20,000 copies, and the CD4 count has dropped. Hey, don't be scared. Stick to the principles. The principle is you only switch when you have two viral loads, two consecutive viral loads above 1,000. So the question here is, how many viral loads do we have that are above 1,000? We only have one. So once a patient has a first viral load that is high, we don't rush into switching. We don't switch, but then we need to have a plan, right? We need to have a plan. So let me stop sharing the results so that then I can assess you in terms of what do you think should be done. So if Lerato came to you today and she had this viral load and a CD4 count, what would be your options? What would you do? What would you do? Read them carefully, and this time you are allowed to choose more than one answer. What would be your plan? You said you won't switch. We agreed that we are not going to switch. Some said they are going to switch. Some. So what would you do? What would you do? All right. What would you do? What would you do? Hey, what sister? You were listening, man. This is exciting. A few more votes, guys. Come on. Choose. You can choose more than one answer, but choose. Yeah, choose. Few more seconds. Come on. Only 60% of you have voted. Come on, vote. It's important to commit. We won't know your answer. We will never know what you selected, but we will use it for learning and for feedback. All right. So I see 80% have voted. Right on, right on, right on, right on. Okay, so I'm gonna stop and then I'm gonna show you the results. So interesting results. So the first one, replace efavirenz with dolutegravir. 2% of the group said we will replace. Remember the golden rule. Never do a single drug substitution. Don't stop one drug and introduce one drug for a patient who has a detectable viral load, right? So yes, the patient is taking efavirenz and we wish she could take dolutegravir, and we know dolutegravir is a good drug, but even dolutegravir would be weak if we introduce it on a patient who's got a high viral load and we only introduce dolutegravir alone. Remember, patients with high viral loads, we need to help them to suppress, and then alternately they need a brand new regimen. Now, ABCD assessment is very important, and 95% of you selected that one. Remember, adherence, check the bugs, infections, check the dosing, drug-drug interactions, and so on. And yes, at this point in time, you might consider doing HB and hepatitis B, because you know if Lerato fails to suppress, she's going to need a second-line regimen, and the likelihood are that you would need to use zidovudine. So you want to check if she doesn't have anemia, and you want to see if you interrupt tenofovir, whether she might be in trouble. So we need to make sure that we check her hepatitis B status. Review visits monthly. Yes, yes, yes. You cannot have a patient with a high viral load and send them home and say, I'll see you in 3 months' time. When will you repeat the viral load? Not 2 months, but 3 months. So remember that, right? You're gonna see the patient monthly for the next 3 months. At 3 months, you then repeat the viral load. And then you will then compare that 3 months viral load with this current viral load, which is 20,000, right? So very interesting discussions, and I'm very excited about it as much as possible. So let's then look at Lerato for the last time. So Lerato comes back at 3 months because you asked her to come back. She says that she has been taking her medicines every day. So during these 3 months, she did exactly the way you advised her after doing the ABCD assessment. She says, Sister Way, doctor, I've never missed any dose. I'm being very good. I have not taken any herbal or traditional medicines. I'm not using alcohol. I'm sound. I have support at home. And you then decide, because now it's 3 months, to draw your bloods for hepatitis B, for HB, together with the viral load, right? Now you have your 3 months viral load. It's back. It's 15,230. If you remember, the first viral load was 20,950. Now you did some adherence issues. You supported. She's back. The viral load is now 15,000. So what are you thinking, my dear sisters, as we sum up today's topic? What are you thinking? What do you want to do? So even this one, you can select more than one answer. I want to see your thinking around it. What would you do? So you've got like many options. So you can either conduct ABCD assessment, check your hepatitis B and HBV results, stop treatment for a while. What is this other one? Switch here to second line. And there's 2 regimens there. Continue current regimen and repeat viral load after 3 months. Refer patient to a specialist. Yeah, safer option. Come on, come on. Let's vote. Read them slowly. You can choose more than one. We will discuss them shortly. We are about to finish. I know we are nearing 9 o'clock, but we are actually done more than anything. So Please be patient a bit. Just 2 more minutes and then we will be done. All right. I see the voting is going. Only 60% of you have voted. What are you scared of? Come on, my dear sisters. Come on, come on. Yay, yay, yay. Don't worry, we'll never know which one you chose. It's for learning purposes. You will reflect when we discuss them. All right, so I'm going to stop the voting now and then share with you the results so that then we can discuss these results. I hope you can see the results. So yes, A, B, C, D, E all the time. Even if the viral load came back suppressed, we would do A, B, C, D, E all the time. Yes, remember we did draw bloods for hepatitis B and HB, and we have to check the results because if we consider switching her to second line, we need to make sure that she's not anemic. And before we stop tenofovir, which is part of her regimen, we need to make sure that she doesn't have hepatitis B. The option of stop treatment for a while is not an option. No one chose it, so we know we are not going to stop treatment for a while. We must make up our minds. And 74% chose that they would switch her to a second-line regimen, zidovudine, lamivudine, and dolutegravir, and that is correct because we have 2 viral loads, more than 8,000, taken 3 months apart. Don't be confused by the fact that it was 20,000 and now it's 15,000. Actually, this improvement is non-significant. It makes no difference. This patient has failed. Considering that it's on efavirenz, the patient has failed. Efavirenz has a low barrier to resistance. So yes, we want to switch her, and the best regimen is zidovudine, lamivudine, and dolutegravir. We don't just introduce dolutegravir in a high viral load. We need at least an extra new drug like zidovudine. The regimen zidovudine, lamivudine, lopinavir, ritonavir is not a bad regimen. You know, before we had dolutegravir, that was our second line. And also, if she was pregnant in the first trimester and we couldn't use dolutegravir, we would opt for lopinavir, ritonavir. Also, if she was not on a reliable contraception and she chooses not to be on dolutegravir, then that regimen would have been ideal. However, zidovudine, lamivudine, and dolutegravir is the best regimen for our patient. And then I know those who said I will continue current regimen and repeat the viral load is because you saw the viral load dropping a bit. The virus is clever. Don't allow the virus to trick you. This patient has failed. He's not a pregnant female. You know, she has failed. So we don't even look at the logs or anything. She has failed and she needs a new regimen and support. Refer to a specialist. Yes, my sisters, you know, that's always your way out. But if you are NIMART trained, you are expected to be able to manage patients who fail an efavirenz-based regimen. If you are not confident to switch regimens, then you refer. You are still a safe clinician. However, with confidence, you should be able to manage those kinds of patients. So the last question for the day is, if hepatitis B comes back positive, what precautions do you do? So what will your regimen look like? So if Lerato, now we have agreed that she has failed, she needs a second line regimen. We agreed that it will be zidovudine, lamivudine, and dolutegravir. Will that regimen be the best for her if she also has hepatitis B? What is going through your mind? Let's do the final question for the day and call it a day. And I'm hoping that this session was good for you. So which of these regimens is suitable for someone who is failing, who needs second line, and they have a positive hepatitis B test? You are at 40% voting. Come on, I need everyone to vote. We must finish on a high note. Come on, 55%, let's vote. My dear sisters, let's vote. You are at 60%. Come on. Hey, vote, 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 please. Right on, right on, right on. Okay, I'm gonna stop it because of time, but I see 75% of you participated, 79, 80%, come on, 100%. Let's all vote. All right, we stop it there. And then I show you the results because our time is up. It's in the evening. Families, they miss us. So yeah, so remember the rule on this one, and maybe remember, in an ideal world, if this patient does not have hepatitis B, the second regimen would be the best: zidovudine, lamivudine, and dolutegravir, right? Where we cannot use dolutegravir, lopinavir, ritonavir would be an option. The issue is this patient has hepatitis B. Therefore, we cannot afford to stop tenofovir. So that third regimen, zidovudine, lamivudine, and dolutegravir, is a good regimen, but we need to ensure that tenofovir as a fourth drug needs to be in the regimen, right? So both tenofovir and lamivudine would then manage hepatitis B, and then zidovudine, lamivudine, and dolutegravir would be the recommended regimen in terms of managing patients who have HIV, hepatitis B co-infection. And I had a slide to summarize this to say, remember, like Lerato, she was taking tenofovir, lamivudine, and efavirenz, right? She developed 2 viral loads, more than 1,000. She needed second line. So her best second line was zidovudine, lamivudine, and dolutegravir. However, she has hepatitis B and HIV at the same time. Therefore, she needs zidovudine, lamivudine, and dolutegravir to control the HIV, and then TDF and lamivudine to control the hepatitis B. She would therefore take 1, 2, 3, 4 ARVs to control both HIV and hepatitis B. Never interrupt tenofovir and lamivudine in patients who have both HIV and hepatitis B. Whenever you are changing a regimen from the first line to the second line, always check the hepatitis B status of your patient. If it is negative, you give them the standard second line regimen. If it is positive hepatitis B, they need 4 drugs for us to win the battle. Ladies and gentlemen, I hope you have enjoyed this evening's session. We have recorded it. If you want to reflect on this session, we will share the links. You also check our Facebook page and our YouTube, account for the videos and podcasts. Play them, teach you for your in-service trainings. Use them and make sure that together with your teams, you are on the same page. So really appreciated you guys staying over until this